Okay, thank you very much for having me. So we're going to be talking about systemic therapies in treating prostate cancer. And this is quite a huge field. Let's move on to this. So what you can see is that this scenario and the landscape has changed dramatically over the years. And initially, we started in this setting over here with the castrate-resistant metastatic patients. But since then, the systemic treatments have flooded through to the metastatic hormone-sensitive. We're now also using them in the non-metastatic high-risk castrate-resistant prostate cancers. We're also then using them in biochemical failure, which is probably the latest finding with the EMBARK trial. And Stampede has now also introduced abiraterone in the locally advanced early stage, stage that's treated with cure. So the landscape has changed dramatically. And you can see all of these drugs that are here have been shown in a randomized controlled trial to prolong survival and have been registered for use in various countries in the world. So let's start with the metastatic hormone-sensitive prostate cancer. I'm not going to speak about abiraterone in the early setting, and I'm not going to speak about the biochemical recurrence. So let's start at this point. So these are those options that I mentioned. And there's some rules that you should always follow. And the first rule in all settings is that you shouldn't challenge with a second novel hormone agent or an ARTA or an RC or whatever you want to call it. And if your patient has been diagnosed with de novo high volume triplet disease and they're able to have chemotherapy, you should always give them triple therapy. That's really important. If you have a look at this lovely review, which was published this year, there are other indications where you may want to use triplet therapy other than that. And that may be that if you've got a high T stage in a Gleason score of 8, if you've got extremely symptomatic disease, if you've got a short PSA doubling time, if you've got a low level of PSA at initial presentation that is not commensurate with the degree of metastatic disease, those patients will benefit. Visceral metastases, especially your liver metastases, and then young age, good performance status, low comorbidity burden, and good tolerability to chemotherapy. You're hardly ever going to use docetaxel as single agent in this setting, other than in this country where you may not have access to add the darolutamide or the apalutamide because of funder issues. And these are the guidelines which have been updated. And I think the important thing is that you must treat with ADT, okay? That you shouldn't use an older generation anti-androgen to prevent flare. You should rather then use an antagonist which is as effective as orchiectomy, as reducing your testosterone levels within 20 to 48 hours. You shouldn't use one of the new agents as monotherapy in this setting. And you should use triple therapy whenever you can. And then you should use radiation in that specific group where you've got low metastatic volume, because that has been shown to improve survival. And you shouldn't offer metastasis-directed therapy in this setting unless you're doing it within a clinical trial. And I think that mostly we all follow those guidelines. This is an interesting paper. It comes from a database in Sweden. And what they had a look at was looking at doublet therapy in metastatic hormone-sensitive prostate cancer. And they had a look at the uptake of this in the patients that were treated in Sweden. And you can see on the graph, sorry, I don't want to get your eyes lasered, Shanaz. You can see that really using upfront immediate within 6 months of diagnosis, doublet therapy only really started taking off in 2017. Okay, and you can see the black line is triplet therapy, where in fact docetaxel was added. So in practice in Sweden, this has only really taken off in the last while. What's interesting then is they had a look at their survival trends as this was introduced. And you can see these 3 lines going from the poorest survival in the early section from 2008 to 2012. And you can see the blue line is in these in the time period where these patients are now being given doublet therapy upfront or triplet therapy. And survival has increased over that time. So in a real world setting, we're actually seeing that this is true. It's not just something that was found in a randomized control trial. And then they have this lovely graph where they look according to year, and they extrapolate how your survival is going to continue to improve in the setting. So let's now move from the metastatic hormone sensitive to castrate resistant. And this is also a review which had a look at outcomes of metastatic hormone-sensitive prostate cancers progressing from first through to 6th line treatment in the castrate-resistant setting. And this is a Sankey plot, it's quite complicated. But you can see that the first graph, which is this one over here, most of the patients were treated with ADT monotherapy. There were a significant number that were treated with an RP. There were some that were treated with chemotherapy or triplet therapy. And then you can see as the patients flow from this to first line, which is there, what's important is these patients here had no further therapy. And as you move from first line to second line, these patients had no further therapy, and so on. So metastatic castrate-resistant prostate cancer is the place where you come to die from prostate cancer, okay? And we have to do our best to get these patients from falling out so that everybody can get first, second, third, fourth, fifth, sixth, and more as we learn more. Because as you add the layers, you improve survival. So that's really, really important, and we should be making our judgments about when to change lines quite carefully. Just to remind you about what castrate resistance is, you need to show that your testosterone is suppressed, and then you can either have a biochemical progression, and there are rules about what that should be, or you could have radiological progression, or both. So if we go back to the graph that I showed you in the first slide, these are your options now that have been registered for use and shown to improve overall survival in the setting. And there are many, okay? And there's some rules. And I, as an oncologist, strongly believe that you need to use chemotherapy in these patients. And you need to use them relatively early while your patient is still fit. We get older, we acquire comorbidities, so that is really important. If you really want to get the best long-term overall survival, you need to use chemotherapy, and preferably both docetaxel and cabazitaxel. Once again, do not sequence RPs. If you failed on one, move on to another class of medication, unless you're scraping the barrel right at the end and you have nothing to offer, including a clinical trial. And then this is where your biomarkers need to come in. So you then, at this stage, when your patient has reached this, you need to look for microsatellite instability to see whether they may be one of those 5% of prostate cancers that may respond to immunotherapy. You need to look at the HRR, and we've discussed that because that would tell you whether they are suitable not just for PARP inhibitors, but for cisplatin, your platinum chemotherapies, which will also have good effects in that group of patient. And then you need to have a look at the PSMA uptake in the cancer to see whether this patient may be suitable for PRRT or protein peptide radiotherapy treatment with lutetium. So it's really important that you do that in the patients when you get here. Okay, so how do you decide from this whole list? Okay, so already we've thrown some of them out because the new novel androgen agents often now will have been used in a prior setting. Okay, and you won't use those again. So you can immediately throw those out. So you've got cancer-related factors, you've got patient-related factors, you've got healthcare-related factors, and you've got treatment-specific factors. So it depends what prior treatment they've had. It depends on how they have responded to the prior treatment, because that also can help you choose what the next line is going to be. You need to know your biomarkers. You need to know where your mets are in terms of whether it's bone only or you've got massive liver and visceral disease. You need to know how much disease and how quickly the disease is growing, especially if you're going to be using chemotherapy. And you need your patient factors. I mean, this is a person who has to actually live through all of this. So you need good performance status. Most of these men have got comorbidities, and those comorbidities have got medications. And there are many drug-drug interactions when you reach the setting. So you need to be able to choose a drug that is not going to harm the patient, because they are on anticoagulation, anti-cholesterol, and many of the cardiac drugs as well. It depends where they live as well. And the funders, I'm not going to go through all the factors here because we are going to run out of time, but it depends what you have access to in terms of funds, because unfortunately, many of these treatments are really quite expensive. And you layering a whole number of expensive treatments one on top of the other. This is an interesting trial, which was a randomized trial looking at cabazitaxel versus Abi or Enza in patients who had failed Abi or Enza, okay? And this trial was how it was structured. So the patients had actually failed already on Abi or Enza. They were then randomized to getting Cabazi or the other one. So if they failed Abi, they'd get Enza or vice versa. And it in fact showed that cabazitaxel far outdoes using a second ARTA. So I put this one in just to emphasize that. Do not use a second novel hormone agent. It's really, really important. There are other things that you can do that have got much more impact on outcomes. Okay, so there are two papers which are quite useful. Francini, which is the panels on this side, and then the panel on that side is McManus. And these are nice, easy pathway flows for you to decide in which sequence you should probably treat your patients. And it depends where you came from. So these panels on this page are for the patient that has reached this phase, that has not had access to chemotherapy or to a novel hormone agent. Okay, so you've got a whole lot of things. But what's important is when you embark on this, okay, you must do your biomarkers, okay? And you must specifically look and see whether you're going to be able to use a PARP inhibitor. Because patients who harbor these PARP these HRR defects have been shown to do poorly on all of the other agents. So you want to come in first. You want to hit that patient with a PARP inhibitor. And that would be monotherapy if they've already had NHA in a previous setting, or else dual therapy. So that's really important. And I'm not going to go through the details. I'm going to try and save us some time as well. So you can see the important thing is that you start off with, you choose one of these agents, depending on all of those factors I mentioned. And then you move on, and then you move on. And there are only 3 lines there, okay? In essence, you need to try and use everything you can to prolong that patient's life. And then this is the two papers that in fact took patients who had HR deficiencies, and they looked at their survival. And these patients do much, much worse when exposed to physician's choice other agents, chemotherapy and the novel agents. So they do much, much worse. So if you've got one of these patients and you are able to show that there's a deficiency and you are able to access PARP, then you really do need to give them that. Sometimes if you can't give PARP, you could also give a platinum as a poor man's option in this setting. But I'm not saying that's what you should do, a PARP. Okay. And then this is the pathways that you can follow when you, actually I've had this slide, let's go here. And then these are the pathways that you can follow depending on if you've been had an RP progressed or DOSI progressed. And it's quite easy. So I'm very happy for these slides to be made available so that if anybody wants a poor man's guide, easy man's guide, just to look up and see, that's really important. And this is an interesting trial that compared lutetium versus cabazitaxel, and one was not superior to the other. Okay, so in terms of sequencing, it doesn't matter really what you do, and it depends on what you have availability of, because lutetium therapy in this country is only really given in 3 cities, whereas cabazitaxel is readily available, and it depends on funding. We get throwback for cabazitaxel, but PRT is ginormously expensive relative to cabazitaxel, but you can use either or in the setting. This is an interesting concept, and I put it in, and it's called androgen annihilation, okay? So in essence, the question is, if we take away the testosterone from the testes with androgen deprivation therapy, and we completely block the production of testosterone by abiraterone, and we block the receptors with one of our new lutamides, surely that's going to give you a better outcome. And in fact, it doesn't, okay? The differences are very, very small, and the toxicity is tremendous. So do not use that as an option. And I don't think any funders in this country would let you in any case. So androgen annihilation is a no-no. Where are we going? Okay, it's very exciting, it's amazing. When I was a registrar, we had docetaxel, and we were very excited about docetaxel. And now look at this plethora of wonderful goodies that I can offer my patients. So as I've pointed out already, there's a shift, and we're moving from this block, and we're moving this earlier through those settings. And what will happen, I anticipate, is in the same way that enzalutamide has now been positioned here, I am sure that the other agents are going to be tested and shown also to be effective in that setting. I would be very surprised if that didn't happen. So that will probably happen in the future. And all of these things that aren't already in this setting over here are currently being tested in that setting, and many of them will move across. And then, if we look, we're going to get new entrants into the castrate-resistant metastatic setting. Many trials going on. Many of us are participating in those trials, looking at a whole lot of new concepts, looking at if we can try and make prostate cancer more immunogenic. So there are various methods of that. Just to tell you that the trials that have looked at trying to move your pembro into the metastatic hormone sensitive have failed. Okay, so hasn't worked. So you're going to have to do something else to get pembro into that setting, and you're going to have to do something else to make the cells more immunogenic. We've got a whole lot of other, we've got abiraterone on steroids that actually block enzymes much further up that cascade. And we've got very novel immune drug conjugates, where you're in fact taking chemotherapy to a target, and we're testing all of those and many other things. So the future is bright. That's the end of my discussion, and I've saved you 5 minutes and 11 seconds.